Well, thanks for having me. I'm really happy to be here. I think this is a really challenging condition, even to this day. And we're now, 5+ years into this, and we still don't have a lot of evidence behind much of what we do. Now it's growing, there's continuing to be research, but certainly more work needs to be done. Today's talk, primarily, I'm going to focus on kind of what we do in our clinic. We've had over 2,000 patients who have seen us in clinic for long COVID symptoms. And so a lot of what we're going to be talking about is based on our anecdotal experience, but also research, uh, similar conditions that have had a little bit more legacy of being studied, such as ME/CFS and POTS. And hopefully we can apply those lessons to our patients that we're seeing. Um, so let me try to advance my slides. So my only disclosure is that I perform some medical advising on long COVID to Pfizer. Um, so objectives for today, understand what kind of the updated evidence is on the management of long COVID, what the guidance statements are saying, and follow what kind of the emerging and next step treatments will be. So I know probably everybody here is familiar with this, but long COVID is really a multi-organ system disease. It's a full body disease. There's no system that is completely spared. Some systems tend to be more involved than others. And this slide, don't look at it in too much detail, but basically it's just the visualization of that. Many times it's systemic symptoms, feelings of general malaise, weakness, loss of endurance. Neurocognitive symptoms are also very frequent, often called brain fog, so different difficulties with focus, talking and word finding, psychological disorders, anxiety, depression, very, very common, pain, super, super common. So almost everything, but I've seen skin issues that people have found new after COVID, rheumatologic issues, things that were previously quiescent, like sleep apnea, and all of a sudden it's raging and they're having to go on CPAP. So it comes in lots of different presentations. So when I see a patient with long COVID, I think there's some essential treatment principles that apply to pretty much all of them. So I often think of these as overlapping symptoms, and I'll get into a little bit more details about that. But some of those focuses of our conversation. One, as of now, there's no cure for long COVID. There's no medicine that you take and your long COVID goes away. Now, everybody would love that, and I would love it, but it's never happened in our 2,000 patients. Instead, we have treatments that make people feel better. So that's where it gets to symptomatic management. And do people recover completely? Yes, many, many patients do recover completely, but it's not a pill that we know of that does that. It's a combination of time and treatments. And oftentimes, once they're feeling better for prolonged periods of time, the long COVID tends to just go away. But there's no medical cure that we know of that is applicable to multiple people with long COVID. It's really individualized and personalized, which is what the second bullet point gets to. Every patient is treated different. And the third bulletproof point. Another really essential treatment principle is optimize any pre-existing conditions they have. So if they have anxiety and depression, if they have chronic pain from osteoarthritis, if they have fibromyalgia, if they have chronic headaches, these things tend to overlap. So if you can, again, peel away at one of them, that can make a big difference. Treat comorbidities, again, very similar to the pre-existing conditions. Uh, these symptoms tend to be intertwined. So I often describe if you're not sleeping because of insomnia that you've started after you have COVID, and then you develop brain fog because you're not sleeping at all and you can't remember anything, and then that leads to anxiety because you're having trouble at school, and then you can't sleep more. So, oftentimes if we can find ways to kind of break that cycle, it helps with many of the symptoms. And the last kind of treatment point is like know who your good providers are, like locally, who have an interest, because it can be really damaging to our patients if they see somebody and they say, "Hey, I've had chronic joint pain and I don't have any positive, you know, rheumatoid factor." Oh, it's all in your head. Go get psychiatric care. You need people who are understanding of what these conditions are and really treat these patients with respect and have some baseline level of knowledge. And sometimes that takes time to build that kind of referral network and hearing back from patients like, oh, I saw so and so and they didn't help. And really, at the University of Pennsylvania, that process led us to finding like a cardiologist who has a real interest now in POTS and is seeing a lot of our patients with POTS and has, is willing to try some more advanced and novel treatments. And I think it's made a real difference for our patients. But that took, time to build. Um, so I often kind of also think about long COVID as this kind of overlap overlapping terminology of these chronic, fatiguing illnesses that may not have a clear biomarker that says you have ME/CFS, you have POTS. Oftentimes we have to look at the full clinical picture. And again, going back to that onion and getting to the most important symptoms, I often start with what's distressing the patient the most. So they come in with a list of 10 symptoms that are ongoing. Which one is the most bothersome to your day-to-day activity? Which one's most central? Again, which one can explain a bunch of other symptoms? I'll go back to that insomnia example. If they're not sleeping because of, insomnia or OSA or whatever it is, it can affect a whole bunch of other symptoms, as you know. And what's most treatable? Like POTS tends to be easier to treat than like chronic fatigue syndrome, ME/CFS. So there's a lot of medication options that we have for POTS. They have a little bit more research backing, although not great. So that may be the way to start as opposed to starting with something that's a little bit more nebulous. So as I go through this, I'm just going to have these slides pointing out the AAPM&R's Long COVID Collaborative, which, full disclosure, I helped write these as one of the chairs of the committee, where we had a multidisciplinary group come together and develop guidance statements. So we have one on the treatment of fatigue in people with long COVID. So one of the most important aspects of treating fatigue in people with long COVID is this idea of pacing. We often use the 4P models: planning, plan out your day; pacing, so try to do everything at once or not try to outdo your energy window; prioritizing, like what needs to be done now, what can be pushed back; positioning, how do we get you sitting more at work? How do we get you closer to work in terms of your parking space? Managing triggers of post-exertional malaise. So post-exertional malaise is extremely common in our patients that have fatigue in long COVID. This is the idea that individuals who kind of overdo it, either physically, mentally, or due to something like stress or things that they eat or drink. Alcohol is frequently a cause. They have these crashes, and these crashes can last days, but they can also last weeks or even longer than that in some cases. So if we know that it's overexertion, how do we avoid that? Also stress, dehydration, weather changes, large meals, alcohol. Again, whatever that trigger is, we try to mitigate it. One way that we also kind of think about this pacing concept, and our speech language pathologists here work really closely with our patients on these concepts, are things like spoon theories. Everybody has a certain amount of energy that they can kind of use up in a day. So how do you use that most appropriately? How do you, if you have 4 spoons and going to work takes up all your spoons and you can't do anything else for that day, is there a better way to kind of return to function by using those spoons more appropriately? Another thing I like to give to my patients, and I have these all like saved in a folder and I give them to patients all the time, is this activity tracker. So if a patient is having boom and bust cycles, what can we identify what those triggers are to their busts? Is it a day, because sometimes it can even happen 2 days later. Is it because on Monday you were out all day surfing in the hot, Hawaiian sun, and then 2 days later you're crashing? Or is it something else? Sometimes that can be helpful, and sometimes we can identify things, sometimes we can't. So, post-COVID physical therapy program, this is somewhat of a controversial topic because it seems in some ways to be to counter what I was just saying about pacing. But we found really individualized and personalized physical therapy programs can be very helpful. And we're actually doing a study funded by NIH looking at long COVID physical therapy program and speech language pathology program to see if it helps our patients or individuals with long COVID. But it has to be individualized. It should not be graded. It should not be like today you did 1 mile on the treadmill, tomorrow you do 2 miles. It's really like let's get you to a steady state and let's build slowly. Oftentimes it's built in POTS treatments, which I'll talk about later. You want providers who are familiar with it. So example program, it may start with just light stretching, range of motion prior to any target cardiovascular exercise, maybe isometric strength training. That means like holding the weights out to your side without lifting them. And maybe just discussing energy conservation techniques and learning with like a PT or maybe even an OT, how do you conserve energy over the course of a day? If patients are doing really well, though, we do start cardiovascular training. We're not 100% against cardiovascular training. It just has to be appropriate and often has to be built to up to. And when we do it slowly with targets and we watch. If somebody has shortness of breath, we're building in breathing techniques, breathing exercises, which I'll talk a little bit more about later. And again, if they overdo it, if they develop any post-exertional malaise, we bring it back. And, there are patients who cannot tolerate this, but it's really the minority. And then I'll just talk about some of the research on exercise. This is even outside of some like more structured physical therapy, but exercises. This is a non-controlled study in individuals with long COVID, showed that it increased muscle strength, reduced shortness of breath, reduced fatigue, improved functional independence, but it didn't have a control group. Now we have a couple studies that do have control groups, and this is an 8-week program of supervised aerobic and resistance training. So again, it's exercise, and we see improvements not only in physical measures like VO2 max, sit to stand, bench press, squat, but also in things like quality of life, fatigue, depression, that are obviously really important. And then, not to kind of reiterate too much, but this is one more study looking again at exercise for long COVID. And again, supervise, and on the left here, I don't know if you can see my mouse. Now I clicked forward. But on the left here, we have our control group. Green is good, so down is good. This is decrease in symptoms. And you can see concurrent training, meaning exercise and respiratory muscle strength testing, and just respiratory muscle strength, there were significant improvements with the actual physical activity and the combined program. And it's not only again physical measures, and I won't go through all these, but also things like fatigue, dyspnea, health status, things like that. Let me click forward. But again, this does not come without controversy. And I can go into a long discussion of where I think this comes from. I think in the past, a lot of the people who had like ME/CFS and other post-viral syndromes were really like kind of the most affected patients. I think now there's a greater kind of threshold to identify these patients, so they're picked up a little bit sooner, and so sometimes we have a little bit more mild of a phenotype. So again, it's not right for everybody, but I think research is pretty consistent that for a lot of people it can be helpful. Now, medications, this is another thing that we were not too overly hesitant to jump to, particularly if they've tried some of these conservative measures without good efficacy. Low dose naltrexone is one option. It's very well tolerated. The mechanisms are thought to be anti-inflammatory, but we don't really know how it works. We're talking about like 1 mg. It usually has to be compounded, but again, patients tolerate it well. I find for patients with brain fog and fatigue, neurostimulants can sometimes be helpful, and I can talk again more about these. Amantadine, modafinil, SNRIs and SSRIs. We have some really interesting research that we were part of here at Penn, looking at the effects of long COVID on systemic serotonin levels. Some general rules: start low, go slow, and if it doesn't work, take it back. Do not keep increasing the dose or just adding on medications. And sometimes I have patients who come to me on like literally 15, 20 medications, And, we don't know the interactions between these medications. We don't know the side effects. So deprescribing for some of these patients is really helpful, actually. Um, this is just a little bit of the research. This is not a controlled trial, so I take it with a big grain of salt, but low dose naltrexone was found to be helpful in many of the different parameters pre and post starting, which you can see on the right. But again, non-controlled study, not placebo-controlled, so very low level of evidence. And then the last thing, with fatigue as a symptom, we really want to support return to activity. So whether that's parking placards, work accommodations, can they work from home 3 days a week? Vocational counseling. These things can be helpful. Long COVID is, a can be considered a disability by the ADA and Health and Human Services. So it is a disability that can warrant accommodations and the reasonable accommodations. And finally, just a quick note on CBT. Again, this study was looking at individuals who had long COVID and they did CBT, cognitive behavioral therapy. And those who did CBT did better. Now, I know this is, again, controversial because then it goes to like, oh, you just think it's all in my head. You're telling me to get CBT. But there's also some, behaviors that can be ingrained in people who have long COVID and addressing these psychological processing, fears, coping, unhelpful beliefs, all these things can be helpful. And I think that's just a product of being chronically ill. Okay, so I'm gonna go through these other ones a little bit quickly so we have plenty of time for Dr. Chow's case today. But um, now we talk about autonomic dysfunction. Again, we have another guidance statement on this topic. Um, and I'm just talking about management, so less about like workup and evaluation, but more on how we manage these. So dysautonomia, again, very common. Mostly it presents as POTS, where little minor activities going up steps causes extremely rapid heart rate. This was a patient who was featured in Wall Street Journal, and he gave me permission to discuss this case. And essentially, he was a runner and starting to do things like brief jogs that, he was a cross country runner, which causes heart rate to go into the 140s, 150s. So we initially treated it conservatively with things like compression stockings, abdominal binder. The abdominal binder is really important. It works better. It does more to maintain that heart rate than just the compression stockings alone. Hydration along with salt, very important. Teaching like physical therapy and physical countermeasures. What do you do if you start feeling lightheaded? What do you feel dizzy? Again, trigger identification similar to what we see in the fatigue world. And then are they on any medications that can exacerbate symptoms? Rehabilitation, again, there's some pretty well developed protocols, including modified CHOP, Levine protocol, that can be very helpful in helping with long COVID. And then there's also some really great work from Mount Sinai in terms of autonomic programs to help people with dysautonomia and long COVID. Again, you still want to watch for post-exertional malaise, not overdoing it. But some patients don't have really post-exertional malaise. They just have the dysautonomia. Um, and then pharmacologic treatment. We have this, we use it not infrequently, but it's usually a kind of second line if the conservative management doesn't work. Um, and this is the study from Sinai just showing benefit for individuals who undergo this autonomic retraining and conditioning therapy. And this is just a list of medications. It's in our guidance statement, the AAP-SILC guidance statement on long COVID. You can kind of see what we think of as like first line. Usually beta blockers we like to use a lot. Fludrocortisone. You just got to watch blood pressure. Same with midodrine. And people ask me, when do I pick one? When do I pick the other? Usually I'll start with midodrine. If somebody says they were like salt really, really helps them, I just based on kind of what I was taught, tend to use fludrocortisone a little bit more, but propranolol for most of our patients is more of the first line agent. But there's a lot of Aberdeen is something that A lot of patients haven't tried yet, and it's been effective for. That's usually our cardiologist, who's kind of who we work closely with prescribing. Breathing disorders, shortness of breath. I find it's often secondary and less of a concern, particularly now compared to those like first two issues. Like if you get the fatigue, if you get the dysautonomia controlled, the shortness of breath, in my experience, has tended to get better. Certainly, this has changed a lot since like early 2020, 2021 COVID, which was very severe and had very bad, lung effects. And some of those times those patients didn't go to the hospital, but their normal pulse ox went from 99 to 90. And so there's, really something significant going on there. Nowadays it seems to be more, again, more secondary, but we always look for those underlying cause. Do they have any sequelae from their COVID infection? Um, and then we talk a lot about breathing exercises and breathlessness management strategies. Um, so these are just some of the types of exercises that we do, breathing control strategies. And then I like this the breather device a lot, which is inspiratory and expiratory muscle strength training. And it's it's cheap, and they actually have nice videos on their website, so they can kind of go through how to do these breathing exercises from home. Next is cognitive dysfunction. So for all the different symptoms, cognitive dysfunction seems to have the most link to the overprescribing in my experience. Um, Again, rehabilitation can be very helpful. I'm a physiatrist, so I'm biased, but speech language pathology, working with our partners there to on one like restorative training, like how do we like practice exercising the brain, but also compensatory training. So if there's something we can't do, how do we get around it? What other strategies can we use? Sometimes we'll also, get neuropsychology on board, particularly if they have more complex cognitive issues or there's mood issues at play here. They can be very helpful at kind of parsing that out and also advising our patients. Sleep, hygiene, insomnia, very important to treat, as well as mood disorders here. And again, similar to like physical activity, we kind of how do we get back into cognitive activities, particularly work in a structured fashion. If they don't have post-exertional malaise, exercise can be great for cognition. But if they do, or they have significant fatigue, not obviously have to take it a little bit slower. And then I mentioned this before when I was talking about fatigue, but I do use neurostimulants not too infrequently for these patients, just with careful monitoring. Neurologic sequelae, so vision changes, again, watch for medications. OT and ophthalmology evaluations can be very helpful. Neuroophthalmology in very infrequent cases, but occasionally. Again, this tends to be secondary, I find, to like the fatigue and the dysautonomia and the insomnia. So if you can get those treated, this tends to get better. Um, Dizziness, vertigo, tinnitus, hearing loss. Again, make sure they're hydrated. If it's postural, we often will go back to that dysautonomia training. If they do have like vestibular issues, vestibular rehab, really great. Patients love it. They do really well with it. For the tinnitus, white noise machines, hearing aids, tinnitus retraining therapy is very difficult to find. I think I've had two, at least in Philadelphia, maybe different, in Hawaii, but I've had like two patients who were able to find it and use it. Biofeedback, acupuncture. This is called the neosensory buzz, I think it's called. Don't quote me on that. But it gives like again that biofeedback and can be helpful. Headaches, we kind of still treat it based on kind of the underlying cause of the headaches. Is it more of a migraine headache or tension type headache? Watch for medication overuse, really important. Are they using ibuprofen every single day? And then supplements that we sometimes use that can be helpful. And then here's some of the non-pharmacologic treatments that we advise for headaches. But honestly, a lot of our headaches, we're getting them in with the headache specialists who can do a lot more like Botox and things that we don't typically do for headaches in our clinic. Excuse me. Insomnia, we're thinking about like CBTI, that's cognitive behavioral therapy for insomnia. Sleep hygiene, get rid of those screens. A lot of times the patients who have lost their jobs and things, we try to get them back on some sort of routine. That's really important. And then medications, we'll use those to help with sleep. But also think about like medications that can treat more than one thing. Are they having like nerve pain too, or cramping, or spasms, or other anxiety, depression? Can we use these things? Pick a medicine that will treat more than one. Um, Smell and taste, like I don't see it anymore. I haven't seen it probably in like at least a year. So if you have questions about that, reach out to me. I'm happy to kind of talk through how we kind of address that. But it's really kind of stopped for my patients. At least I had patients who would see me early on that like only had loss of smell and taste, and that was like their only issue. Now, if you were to ask about it, they may say, "Oh yeah, my smell and taste is a little bit different," but it's not. It's number 10 on their list of ongoing symptoms. So I'll get through the smell stuff. Mental health symptoms. So this is something that like you just have to like address it in a way that is respecting the patients and where they're coming from, because these patients oftentimes have serious mental health issues. It can be underlying, but it could also be secondary to how, they've been sick for a year and they can't do their activities. They can't go out and, see their friends and things like that because they're so exhausted after their day of work. That isolation can be depressing, so I always kind of approach it from the fact that like it's these things are not like mutually exclusive. They feed off one another and they can be again cyclical. If there's social stressors, we try to address those. We're fortunate to have a social worker in our clinic that can help with some of these. But I say like my patients, and I believe it. If you're chronically ill for years on end, you have some sort of secondary mood issues to that, and you would probably benefit from seeing somebody to kind of discuss those, and it doesn't help to keep them bottled up. And then psychiatric evaluations, medications, things that we talk about, and then again addressing uncertainty, I think is an important part of it. Uh, Bone and like muscle pain, joint pain. Again, look for underlying etiologies, and basically we treat this very similar to like fibromyalgia and follow kind of a lot of the same treatment options. Anticonvulsants, SNRIs, TCAs, appropriate therapy, pool therapy. Again, really good option for a lot of our patients, and really getting back into some of that physical therapy. Uh, Vaccination. So I advise most of my patients to maintain their boosters, to get vaccinated if they're unvaccinated, although most of my patients have been vaccinated in Philadelphia. Um, there have been some studies that show that it may help with patients who have established long COVID to get vaccinated. Now, if a patient says, I had the booster and my last one, I was out of it for 6 months and I couldn't work and, felt terrible, nothing's universal, so we really individualize every element here, but, that is part of, I think in general, I always put the counterpoint at, for people who I was sick for 2 days afterwards. Well, what if you get COVID again? Because the amount of people I see who get recurrent COVID and get symptoms for, months on end is extremely frequent. So, in the last couple minutes, I just tried to look up. It's the clinical trials website is not as easy to use as it once was, but at the current moment, about 159 studies looking at long COVID, about 108 prospective treatment studies. It looks like again, you can't filter it like you once were able to. The Recover Trial Initiative was $1 billion federal project looking at long COVID, including phenotyping, collecting blood work, but also doing various trials. One it was Paxlovid. This is looking at a longer course, and I can kind of talk more about this. But one was Brain HQ, looking at eSIM of the brain and goal management training. One was Avabradine IVIG for dysautonomia and autonomic symptoms, cardiopulmonary rehab and structured pacing. It's kind of like their exercise trial. And then the two in bold here are ones that I believe are still recruiting. That's the one looking at these wakefulness agents. as well as the one looking at sleep interventions. There's a lot of backlash because many patients and patient advocacy groups felt these studies were not novel enough. They're not looking at like treatments that patients stated were effective. Like again, it goes back to like some of the pushback against exercise. So this Recover TLC program is really taking input from patients on patient priorities and what medications they would like studied. And the plan eventually, I believe, is to turn these into clinical trials. So just to kind of wrap up here, as of now, I am of the belief that we don't still to this day, while we have some really interesting studies, we are not able to address the underlying pathophysiology. And I kind of go back and forth on how important that is. For a long time, I felt like, until we understand that, we can't get anywhere. But I've kind of, changed my tune over time. And I think instead of thinking of these as separate, like kind of causes, I think a lot of it, there's probably some common pathways. And if we can find treatments that seem to work for a lot of our patients, that might be our ticket to find kind of reverse engineering what that common pathway is that helps patients. But it's complicated. Again, address comorbidities, underlying health issues, premorbid conditions. I take a palliative and symptom-based approach. I I honestly am very infrequently looking at like what is their like CRP, just more to use those to rule out other conditions than to tell me what treatments to approach. Symptoms are interconnected, so if we can address one symptom, others tend to get better. Providing patients with self-management tools, things that they can do on their own, if they're feeling bad or not, that can be very helpful. And these are I set mutual goals with patients, and usually they include feeling better, improving function, and if there's specific things they want to do, how do we get them to do that? Travel, going back to school, things along those lines. Uh, I've seen patients years out recover 100% fully. So it can happen late. It tends to happen slow. Now, usually the later it is, the harder it is to treat, but certainly happens. Change is incremental. And oftentimes it's like one of those things like watching your kids grow up. They don't ever look bigger to you, but when you see your nephew grow up, they jump up, bigger and bigger every time you see them. They may not ever get back to like 100%, but most of my patients, even the ones who have recovered, they'll say, hey, if I go for a mile swim and I don't, get any sleep that night, it takes more out of me than it used to. But we want you functional. We want you to be able to, again, pursue those things that you love. Continuity of care with these patients is very important. Stay in the loop with them, see how they're progressing, see how their treatments are affecting their conditions. Be that point of contact for them. Last thing, we created a long COVID compendium from AAPMNR now that's recently been published within the last few months. And that kind of takes all these different guidance statements and mushes them all together into something that we hope is a little bit more provider friendly in terms of giving people the tools they need. Biomarkers, I think this is at the golden egg. This is what everybody wants. We're not there yet, but I think if we are able to find it, it likely will change the way we treat this condition. These are just my references and more references. And that's it. So I will stop sharing my screen, I believe, and allow Melissa to keep us going. Thank you so much for having me. Hope to visit you guys. Invite me in person next time. I'll be happy to come visit.
Thanks, Dr. Abramoff. Thank you for giving us some avenues of where we could be in terms of treating our clients. And while Melissa's getting up the slides, I do, for the clinicians and staff and also patients who are on the call, if you wanted to put in, obviously you could ask us questions. You could also put it into the chat as far as questions that you have. I did have a couple of questions before I give you the case. Do you think that CPE testing is kind of important for patients to do if they have severe fatigue? There's this whole notion of respiratory, cardiac, and mitochondrial abnormalities, and will CPET be able to discern which which is the problem among the patients?
Yeah, so I used to think that the CPT, the CPETs kind of tended to show a couple like they showed this diminished respiratory like uptake that seemed like there were two possibilities. One was like autonomic dysfunction causing like shunting of the peripheral blood. And I'm not, and then the other option was, well, was it the mitochondria that are dysfunction? And for a while, it made a lot more sense to me that it was more the former. But more recently, over the last couple of years, there's some really interesting and compelling evidence that there's potentially mitochondrial dysfunction in these patients. Now, they don't necessarily have like I work with CHOP, the Children's Hospital of Philadelphia, mitochondrial experts, and I have a good friend who's one of the physicians there, and there's no like mitochondrial testing that shows that there's, like clinical testing or genetic testing that shows that there's mitochondrial dysfunction, at least in the patients that have gone through their program, and we've had some mutual patients. Um, so, and then what would be the treatment even if there was found? It'd probably be like this like mitochondrial supplements and like diet, which, Dr. Chow may be more well versed in than I am. But for the most part, the information that we get from that testing in my patients has not been particularly actionable, and it can be a very difficult test to undergo. Now, what are the circumstances where that honestly it seems to be the most helpful? For patients who are like really severely dysfunctional and they're having trouble getting like disability and they can't work, sometimes having that objective evidence from a CPET can be very helpful. And then the other time that it's been kind of we've used it as in kind of high level athletes who are trying to kind of get back to their previous performance. And then in some of those cases, we see really dramatic, findings and differences that don't make sense with their level of like physical fitness, and it's usually not a physical fitness issue. So I don't routinely prescribe CPETs, but there are kind of one-off cases that we do use it, but it doesn't. We get that pattern of like decreased peripheral oxygen like absorption, and it doesn't. We don't have an answer, and so it kind of goes back to treating dysautonomia and like maybe supplements, but again, I don't think we have enough evidence to pursue that.
And so my other question was, do you suggest CHOP for everyone with dysautonomia, or do you think it's a little too rough? Some of our clients have used, or I've suggested the CHOP protocol, as Dr. Levine had mentioned,
Yeah.
but they often are so exhausted after doing even one of this lowest level of it. And do you think it's worth doing, or how would you start someone on initial activities?
Yeah, so it all goes to what kind of their like what they tell me in the clinic visit about how activity affects their symptoms. So if they tell me that doing the walking and doing like kind of day-to-day activities, they get post-exertional malaise or they get extremely fatigued, or they kind of just say like, I can't exercise, it makes me feel too crappy. Then I start with a much more basic program, which would be even just mobility and range of motion and things like that. And maybe kind of going back to that Petrino Mount Sinai protocol, which is even like less pure exercise than something like the CHOP protocol. So I let the patients kind of tell me and kind of base it off of that. But again, I have some patients who like have no problem with like exercise. It's all dysautonomia and they do fine with it.
Yeah, so the other one is you kind of answered a question on which biomarker, or is there basically there are no biomarkers to look at progression of long COVID. Someone mentioned, or have you noted a drastic difference in symptoms between those with hypercholesterolemia versus those with normal cholesterol levels?
So, to answer that question, no, no, but I haven't really been looking for it necessarily, and I don't routinely order cholesterol levels on my patients. Maybe if there's evidence that I should be, I learned a lot from you guys too, but no, but I haven't been looking for it, so I can't answer that to be honest with you. And just going back to the biomarkers, I get blood work to rule out other conditions not to diagnose long COVID. So if I'm worried about a rheumatologic disorder, and I've had patients with heart failure, I've had patients with rheumatologic conditions, it happens. Um, but it's the small minority. Most of my patients are normal, and then we have research studies where we look at kind of more intensive blood work. But even those are like they're not clean, like they're like you have these like heat maps, and like maybe there's more clustering of COVID patients in a certain immune profile, and these studies are all coming, but it's not, or there's like a more tendency to evidence of potential reactivation of like EBV and CMV in these patients, but it's not clean. So like, what are we saying to those patients who aren't on that like side? And maybe we need it. Maybe we need it for like our treatment trials, and I think we have to be looking at those type of biomarkers. But in terms of my clinical day-to-day treatment, I don't think we're at the point where we can really use those so helpfully, I guess is the word.
Melissa, can you advance the slide? So this is one of our cases that we have here in our clinic, a 50-year-old female who has persistent fatigue, shortness of breath, dysautonomia with possible POTS, cognitive dysfunction, which brain fog, tremors, and post-exertional malaise, many similar to your patients that you've had COVID back in 2021, have had a recurrence in 2023, and more recently had a bout of COVID, which resulted in a really lot of brain fog type issues, where the patient would say about neural inflammation. And so the current therapies for the patient was salt loading, compression socks. We recently tried a course of ivermectin because we were a little bit desperate during the time of which she had gotten the long COVID, a second bout or deferred bout of acute COVID. And we were in the process of kind of ramping up amantadine. Patient has done TMS therapy. Again, um, did poorly, got a little bit better, and then with each bout of COVID infections has had a bit of a slide at each of the time frames. Takes a lot of supplements in terms of I clustered it to hormonal, mitochondrial, inflammatory, and microbiome. And you could see the list of supplements from cetirizine for things such as mast cell activation, progesterone, estrogen, acetylcysteine, vitamin C, quercetin, the flavonoids, soybean, fermented nattokinase, acetylcarnitine, glutamate, vitamin E, calcium, vitamins, nicotinamide, alpha lipoic acid, and the list, as you see, for the final ones for more of a microbiome. So next slide. So you can see objective findings. She had a positive active stand test in which there was a greater than 10 millimeter drop in blood pressure, but heart rate remained only increase of 10 beats per minute. She had severe fatigue, and the 6-minute walk test showed that she was only able to do 1,000 feet, but then had lots of symptoms of feeling foggy and woozy. And you can just see the active stand test as our physical therapist had done. You can see that the blood pressure goes from 127 all the way down to about 100. And then you can see the heart rate response. Next slide. And so the chest X-ray was normal, brain MRI was normal, sleep showed possible OSA, and you could see the labs were all within normal, but the D-dimer was slightly elevated at 511, and the cortisol level in the morning, which I thought would have been a lot lower, but was normal. Next slide. And so with the patient, we crafted the following questions. Was for viral control. She has been really bedridden for 2 to 3 months with setbacks due to viral exposure and reactivations. What advice do you have in reducing neuroviral exposures? Would antivirals such as acyclovir, maraviroc, famciclovir, be helpful in these to help her with her neuroinflammation, which is the second one. So maybe we could start with the first two in terms of inflammation and neuroprotection, and then we'll go down to 3 through 8 after you've given your suggestions.
Yeah. So I think first off, this is Dr. Tyler, really good workup. I think really well thought out, and kind of your initial approach is like spot on. So, I think you're like really on the kind of the right track with how you're, thinking through this case. Um, Again, I don't tend to think about it in these like kind of terms. I think about it more like my fatigue, my brain fog, like how do we treat that? Because I just think a lot of times we don't know enough about the underlying pathophysiology. How much is EBV reactivation really a cause, or is that just an immune phenomenon based on kind of your immune system being ramped up and it's kind of response to COVID, things like that. I don't know the answer. I personally don't know the answer to those questions. Now, I think of all the antiviral medications, for me, for a long time, Paxlovid was kind of the most interesting question and answer. And I don't know if your patient take Paxlovid with any of her acute infections. And one thing she had taken it and she had like a good response, or she felt really well with it, or it really made a difference. There are patients I used to pretty routinely put patients on 10-day courses for the most part of Paxlovid. Now, is that enough? When we think about like chronic viral infections, hepatitis C, other ones, people are on months of antivirals to really clear it from the system. Um, but there were two studies that have come out now with very short courses, like 10 to 14 days, that have not been positive for Paxlovid. Again, that recover study with 25 days has not resulted yet. So I think the jury may not be out yet. And I think, again, it's helped some, it doesn't help others. Like, are we taking too much of a like generalized sample, and we're not looking at like they weren't, at least in these studies, weren't looking at like stool levels of SARS-CoV-2 antigen and things like that. So maybe we're just taking all comers. But the thing about Paxlovid is it's really well tolerated for the most part. The one thing you have to watch out for is like medication interactions. So that might be one that I tend to start with if I'm looking down that route. But again, I like neuroinflammation, neuroprotection. I don't think about it in those terms. Like low dose naltrexone, I think is a great medicine for a lot of our patients, and I wouldn't say I love it, but I like it a lot
Mm.
because it helps a lot of our patients, and it's again super well tolerated. You can start really, really low. You can titrate it kind of as the patient needs. And patients have just, in my, and again, anecdotal experience, the research is still kind of being developed, have responded really well to it. So guess I didn't really answer your question, but hopefully, it gives some
Sure.
idea of how do I approach it.
So a suggestion of a 10-day course of Paxlovid and then consideration of the low-dose naltrexone is still kind of considering to kind of quell the neuroinflammation. Have you used a lot with, in terms of the NAC, N-acetylcysteine, or do
A
you?
lot of patients come like do it on their own and have been on it. I don't like necessarily like recommend it because it's not something I like reach for necessarily on my like high on my list. But for supplements in general, and it kind of goes back to the supplements your patient's taking. My approach is if it's not clearly helping, try it for a few weeks or a month, and then take it off. Because what happens, like, especially in a situation like this, is like they're on 20 different supplements. You don't know what's helping, you don't know what's hurting, you don't know the combination. You're coming off one and putting on another one. I think it gets really challenging, and like the cost, has to be astronomical, I imagine, for this patient. So um, I think it's totally fine to try, but I would think about, and this kind of comes to other points, like maybe coming off of some of those first and seeing how, if they're actually making any types of difference for this patient.
Yeah, so for question number 3 and 4, I think it's more like the immune regulation in the mast cell. What do you do to confirm a mast cell activation, and do you ever use IVIG in your practice?
Yeah. So mast cell activation, true, tryptase elevation, mast cell activation syndrome um, is very rare that we see that. But tryptase is like the lab test we'll go to just to check if we think, but they have to be kind of in a flare of like, and usually there's like skin changes and flushing and things like that that go along with it. And usually it's negative. I think I had one patient this whole time that really was diagnosed from an allergist with MCAS. So the approach I take with this is if they have like real clear like sensitivities. Like some patients are like, I can't eat X without having a flare, we will, take them off of it. I do, be back in the day and like things along these last like 5 years have been like really like hot and popular for a while, and then they kind of go out of like the patient community as like popular options. But for a long time, patients were like, I'm sure I have MCAS. And so, and I want to try treatments. And we'll try I do dual antihistamines and we'll see how they kind of feel on that, just watching for like the increased sedation that can be seen with those agents. But if they don't notice any change, we don't necessarily just do it to do it. And sometimes with like diet, again, patients are usually and often able to like tell us their triggers. I don't usually recommend unless it seems like really clearly food related. I don't recommend any like elimination type diets usually, just more of a healthy diet and a balanced diet, Mediterranean type diets. Um, and then IVIG, I don't use IVIG. If a patient has a lot of neuropathy symptoms and small fiber neuropathy symptoms, I will establish them with neurology to kind of be evaluated for that and get maybe a biopsy and things like that. But um, uh, I'm not directly prescribing IVIG, though some do. But again, it's like a big gun. It's expensive. It takes a lot of prior auth. So I don't think the research is out there. And I think, there's a possibility of a pretty high placebo effect
Mm.
with those medications.
Yeah, I think Recover is going to hopefully answer that question with the IVIG and Ivabradine study.
Yeah.
And then energy and cognition in terms of mitochondrial, do you do any mitochondrial sequence support or anything
No,
like
not usually. I mean, again, like I'm not against it, but eh, this that goes back to kind of what we are talking about, like CPET. It may be possibly helpful, but I have like my patients have come in on all sorts of supplements. I'm just not very convinced, either through research or even through the patient experience, that they help. So I do those other things, again, neurostimulants, exercise if it's appropriate, insomnia, fatigue addressing. We do a
that?
lot of that before um, getting to like drugs for it. Although we do use them sometimes.
And so I think for the big picture, that the last question, I think we answered the monitoring progress, but three big things, which is, I heard you say it's pacing is probably one of the big factors and priorities for patients. What would you say would be the big picture for this patient in terms of getting the patient back on track?
Yeah, I think if I saw this patient in clinic, I'd start by kind of trying to like maybe do a little bit of a clean slate and see like let's kind of simplify things in terms of your like regimen and medications. And if maybe they all help, but if they're not helping, even things like we've given them a mantidine, and you said you're just kind of starting and kind of going up on it, but like if it's been 2 months or the ivermectin they've been on for a while and it's not helping, just take it off because again these things can have interactions, even some of the supplements. And I didn't look through the whole list and think about each one, but they can cause GABA and stuff like that, can cause fatiguing type symptoms. So wean off of that would be one of my suggestions. The other thing that I saw in the history is just this OSA. I had a patient for like relatively skinny, not super obese, um, gained like 9 pounds, 10 pounds with their COVID because they long COVID and they weren't as active. And they developed sleep apnea and treating the sleep apnea and like kind of surprised us all that she actually had it. And treating that got her out of long COVID. It just fixed the problem. So I would certainly address that as consideration. And then, again, going back as part of the pacing, and it depends on kind of how she responds to activity, but kind of smart, thoughtful physical therapy program, and it looked like she may have had it because you said the physical therapist did the standing test, the 10-minute stand test. But can that be helpful along with cognitive retraining, cognitive therapy program, maybe pool therapy? Those would probably be some of the places I would start. And then just kind of pick out like which symptom is most bothersome and like what can we do to kind of start to pull it apart a little bit.
Yeah. And then I know that the in the chat there was a mention about statins. Do you use statins for inflammation in terms of those? And then have you seen severe decrease in white blood count? And have you considered using EPO in those cases?
Yeah. So in terms of the first question, statins, like statins were like really well often used early on, very popular treatment regimen. There just wasn't like in what I saw like a great ton of success, and patients had like side effects and increased myalgias and things like that with them. And then there just hasn't been research kind of out there supporting it that I know of as like any type of high quality like trials or treatment options. So I don't that's not on my list of, and I have a lot of things I grab, but that's not one of the ones I really grab to very often. Um, I haven't seen severe decreases in white blood cell counts, and if I did see that, my radar would be going off, and I'd be sending them to hematology and seeing what else could be going on because I would not. That's one of those things that I would not attribute to long COVID. Long COVID, usually the labs, like maybe D-dimer's a little high, maybe CRP's a little high, but labs are usually stone cold normal in these patients.
Melissa, do you have, is there anyone else who has questions?
Let's see. I'm not seeing anything else coming up with in the chat. So it's 5:01. So I think we can probably end there if nothing else comes up. So thank you so much, Dr. Abramoff, for joining us today. And thank you, Dr. Chow, of course. Our next session is going to be on October 28th, and it's going to be the mental health aspect of long COVID. So join us then. Thank you.